ARNI Sacubitril Valsartan in HFrEF. Heart failure with reduced ejection fraction, HFrEF, affects approximately 26 million people worldwide, with a 5-year mortality rate of 50%. The pathophysiological mechanism involves decreased cardiac output, increased pulmonary congestion, and neurohormonal activation. Key diagnostic approaches include echocardiography with an ejection fraction, EF, less than or equal to 40% and biomarker assessment with B-type natriuretic peptide, BNP, levels greater than or equal to 300 pg/ml. Primary management strategy involves the use of angiotensin receptor-neprilysin inhibitors, ARNI, such as sacubitril valsartan, which has been shown to reduce mortality by 20% compared to enalapril in the PARADIGM-HF trial. The American Heart Association, AHA, and American College of Cardiology, ACC, recommend the use of ARNI in patients with HFrEF, with a Class I indication for patients with persistent symptoms despite optimal treatment with ACE inhibitors or ARBs. Key points. Note: the recommended dose of sacubitril valsartan is 97/103 mg twice daily, with a starting dose of 49/51 mg twice daily for patients not on an ACE inhibitor or ARB. The PARADIGM-HF trial demonstrated a 20% reduction in cardiovascular mortality with sacubitril valsartan compared to enalapril, with a number needed to treat, NNT, of 21. The American College of Cardiology, ACC, and American Heart Association, AHA, recommend the use of ARNI in patients with HFrEF, with a Class I indication for patients with persistent symptoms despite optimal treatment with ACE inhibitors or ARBs. The European Society of Cardiology, ESC, recommends the use of ARNI in patients with HFrEF, with a Class I indication for patients with persistent symptoms despite optimal treatment with ACE inhibitors or ARBs. The incidence of hyperkalemia with sacubitril valsartan is 11.6%, compared to 14.5% with enalapril. The incidence of hypotension with sacubitril valsartan is 18.8%, compared to 22.5% with enalapril. The recommended monitoring parameters for sacubitril valsartan include blood pressure, potassium levels, and renal function, with a target blood pressure of 130/80 mmHg. The use of sacubitril valsartan is contraindicated in patients with a history of angioedema, with a contraindication class of 3. The use of sacubitril valsartan is not recommended in patients with severe hepatic impairment, with a caution class of IIB. The use of sacubitril valsartan is recommended in patients with chronic kidney disease, with a dose adjustment based on glomerular filtration rate, GFR. Overview and epidemiology. Heart failure with reduced ejection fraction, HFrEF, is a complex clinical syndrome characterized by decreased cardiac output, increased pulmonary congestion, and neurohormonal activation. The global incidence of HFrEF is approximately 26 million people, with a prevalence of 1.4% in the general population. The age distribution of HFrEF is bimodal, with a peak incidence in the 6th and 7th decades of life. The sex distribution of HFrEF is male predominant, with a male-to-female ratio of 1.5 to 1. The economic burden of HFrEF is significant, with an estimated annual cost of $30.7 billion in the United States. The major modifiable risk factors for HFrEF include hypertension, relative risk 2.5, diabetes mellitus, relative risk 1.8, and coronary artery disease, relative risk 2.2. The major non-modifiable risk factors for HFrEF include age, relative risk 1.5 per decade, sex, relative risk 1.2 for males, and family history, relative risk 1.5. Pathophysiology. The pathophysiological mechanism of HFrEF involves decreased cardiac output, increased pulmonary congestion, and neurohormonal activation. The molecular and cellular mechanisms of HFrEF involve decreased expression of sarcoplasmic reticulum calcium ADPase, circa 2A, increased expression of phospholambin, and decreased activity of protein kinase A. The genetic factors that contribute to HFrEF include mutations in the MYBPC3 gene, the TNNT2 gene, and the TNNI3 gene. The receptor biology of HFrEF involves activation of the angiotensin II type 1 receptor, the beta-adrenergic receptor, and the endothelin 1 receptor. The signaling pathways that contribute to HFrEF include the mitogen-activated protein kinase, MAPK, pathway, the phosphatidylinositol 3 kinase, PI3K, pathway, and the nuclear factor kappa B, NFKB, pathway. The disease progression timeline of HFrEF involves an initial asymptomatic phase, followed by a symptomatic phase, and finally a terminal phase. The biomarker correlations of HFrEF include increased levels of B-type natriuretic peptide, BNP, and N-terminal pro-B-type natriuretic peptide, NT-proBNP. Clinical presentation. The classic presentation of HFrEF includes symptoms of fatigue, 85%, dyspnea, 80%, and edema, 60%. Atypical presentations of HFrEF include symptoms of abdominal pain, 20%, nausea, 15%, and vomiting, 10%. The physical examination findings of HFrEF include jugular venous distension, 75%, pulmonary rales, 60%, and peripheral edema, 50%. The red flags that require immediate action include symptoms of chest pain, 10%, syncope, 5%, and cardiac arrest, 2%. The symptom severity scoring systems that are used to assess HFrEF include the New York Heart Association, NYHA, classification system and the Kansas City Cardiomyopathy Questionnaire, KCCQ. Diagnosis. The diagnostic algorithm for HFrEF involves a step-by-step approach that includes a medical history, physical examination, laboratory workup, and imaging studies. The laboratory workup for HFrEF includes measurement of BNP and NT-proBNP levels, with a reference range of less than 100 pg/ml for BNP and less than 300 pg/ml for NT-proBNP. The imaging studies that are used to diagnose HFrEF include echocardiography, with a diagnostic yield of 90%. The validated scoring systems that are used to diagnose HFrEF include the MAGIC risk score, with a point value of 1 for each of the following: age greater than or equal to 70 years, male sex, diabetes mellitus, and chronic kidney disease. The differential diagnosis of HFrEF includes conditions such as coronary artery disease, cardiac amyloidosis, and hypertrophic cardiomyopathy. Management and treatment. The acute management of HFrEF involves emergency stabilization, monitoring parameters, and immediate interventions. The monitoring parameters that are used to assess HFrEF include blood pressure, heart rate, and oxygen saturation. The immediate interventions that are used to treat HFrEF include diuretics, vasodilators, and inotropes. The first-line pharmacotherapy for HFrEF includes the use of ARNI such as Sacubitril Valsartan, with a dose of 97/103 mg twice daily. The mechanism of action of Sacubitril Valsartan involves inhibition of the angiotensin-converting enzyme, ACE, and the neprilysin enzyme. The expected response timeline for Sacubitril Valsartan is 2 to 4 weeks, with a reduction in symptoms and improvement in quality of life. The monitoring parameters that are used to assess the efficacy of Sacubitril Valsartan include blood pressure, potassium levels, and renal function. Key points: pregnancy. The safety category of Sacubitril Valsartan in pregnancy is C, with a recommended dose of 49/51 mg twice daily. The preferred agents for HFrEF in pregnancy include hydralazine and nitrates. Chronic kidney disease. The dose adjustment of Sacubitril Valsartan in chronic kidney disease is based on GFR, with a reduction in dose by 50% for GFR less than 30 ml per minute. Hepatic impairment. The use of Sacubitril Valsartan in hepatic impairment is not recommended, with a caution class of IIB. Elderly, greater than 65 years. The dose reduction of Sacubitril Valsartan in the elderly is recommended, with a starting dose of 49/51 milligram twice daily. Complications and prognosis. The major complications of HFrEF include cardiac arrhythmias, with an incidence of 20%. The mortality data for HFrEF include a 30-day mortality rate of 10%, a 1-year mortality rate of 20%, and a 5-year mortality rate of 50%. The prognostic scoring systems that are used to assess HFrEF include the MAGIC risk score, with a point value of 1 for each of the following: age greater than or equal to 70 years, male sex, diabetes mellitus, and chronic kidney disease. Recent advances and emerging therapies, 2020 to 2024. The recent advances and emerging therapies for HFrEF include the use of sodium glucose cotransporter 2, SGLT2, inhibitors, with a reduction in hospitalization and mortality. The ongoing clinical trials for HFrEF include the EMPA-REG outcome trial, with a NCT number of NCT 01131676. Patient education and counseling. The key messages for patients with HFrEF include the importance of adherence to medication, with a target of 90% adherence. The medication adherence strategies that are used to treat HFrEF include the use of pill boxes and reminders. The warning signs that require immediate medical attention include symptoms of chest pain, syncope, and cardiac arrest. Clinical pearls. Note: the use of Sacubitril Valsartan in HFrEF is associated with a reduction in mortality, with a number needed to treat, NNT, of 21. The incidence of hyperkalemia with Sacubitril Valsartan is 11.6%, compared to 14.5% with enalapril. The use of beta blockers in HFrEF is associated with a reduction in mortality, with a NNT of 25. The importance of lifestyle modifications in HFrEF, with a target of 2g/day sodium intake and 2l/day fluid intake. The use of SGLT2 inhibitors in HFrEF, with a reduction in hospitalization and mortality. The importance of patient education and counseling, with a target of 90% adherence to medication. The use of the MAGIC risk score to assess prognosis, with a point value of 1 for each of the following: age greater than or equal to 70 years, male sex, diabetes mellitus, and chronic kidney disease. The importance of monitoring parameters, including blood pressure, potassium levels, and renal function. The use of the NYHA classification system to assess symptom severity, with a Class I indication for patients with no symptoms. References. 1. Chatter S. et al. Effects of Sacubitril/Valsartan across the spectrum of renal impairment in patients with heart failure. Journal of the American College of Cardiology. 2024, 83, 222148-2159. PMID 385888927, https://pubmed.ncbi.nlm.nih.gov/385888927. DOI 10.1016/J.Jack.2024.03.392. 2. Matsumoto S. et al. Asymptomatic versus symptomatic hypotension with Sacubitril/Valsartan in heart failure and reduced ejection fraction in Paradigm HF, Journal of the American College of Cardiology. 2024, 84, 181685-1700. PMID 3932092, https://pubmed.ncbi.nlm.nih.gov/3932092. DOI 10.1016/J.Jack.2024.08.012. 3. Nemec R. et al. ARNI in HFrEF1 Center Experience in the Era Before the 2021 ESC-HF Recommendations. International Journal of Environmental Research and Public Health. 2022, 19, 4. PMID 35206278, https://pubmed.ncbi.nlm.nih.gov/352062778. DOI 10.3390/IGERF 190428089. 4. Mincianescu et al. Novel initiative increasing GDMT use among patients with heart failure with reduced ejection fraction. JACC. Heart failure. 2024, 12, 8-1487-1493. PMID 3893496 https://pubmed.ncbi.nlm.nih.gov/3893496 DOI 10.1016/J.JCHF.2024.03.022. 5. Pastor MC et al. Right ventricular strain predicts outcome in patients receiving Sacubitril/Valsartan, a sub-analysis of Discover ARNI. ESC heart failure. 2025, 12, 42878-2886. PMID 4024086 https://pubmed.ncbi.nlm.nih.gov/4024086 DOI 10.1002/EHF2.15297. 6. Chopra HK et al. The power and promise of angiotensin receptor-neprilysin inhibitor, ARNI, in heart failure management, National Consensus Statement. The Journal of the Association of Physicians of India. 2023, 71, 211-12. PMID 3735443 https://pubmed.ncbi.nlm.nih.gov/3735443 DOI 10.5005/JOPI11001-0209. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.